Welcome to Grand Rounds. Thank you for attending. Excuse me. I'd like to introduce Dr. Natalia Murinova, who is a clinical assistant professor of neurology and headache specialist at our institution. She was born in Bratislava, Slovakia, and attended Comenius University. And then moved on to receive her to attend a medical residency at Henry Ford Hospital in Detroit, where she finished in 1992. Between 1995 and 2002, she practiced internal medicine and was involved in a host of related activities, including ICU and outpatient general internal medicine. And then in 2001, she changed gears and decided to become a neurologist and began training at the University of Washington. In 2006, she did a headache fellowship here at this institution and became one of our faculty members in 2007. She's deeply involved in resident education and fellowship training in headache, and today she'll be presenting some data on suicide headaches and trigeminal cephalalgias. Thank you.
Can you guys hear me okay? Okay, great. So thank you very much for coming. So today I'm going to be speaking about suicide headaches and other trigeminal autonomic cephalalgias, and the question, really suicide headaches, and some of our nurses today asked me, Natalia, is it just a pun, or are there really suicide, and so you'll get the answer to this. So all of you have probably seen and heard of Harry Potter, right? Who in this audience has not heard of? Okay, and okay, so there's one guy asking for trouble, but and if you say, what does Harry Potter have to do with suicide headaches? So you remember that Harry had a scar, and anytime he got close to the Dark Lord, who shall not be named because I don't want to get in trouble, he got excruciating headaches that were debilitating. Okay, and so I'm not proposing that Harry Potter had cluster headaches. However, it turns out that the actor who played Harry Potter, Dan Radcliffe, actually is suffering from cluster headaches, and fortunately he finished the filming of the series before he developed these headaches, because now he has been unable to continue filming. He actually had to cancel a number of professional commitments, and per his own account, he said he was in the middle of weird things called cluster headaches. I'm so sorry, guys. Getting unplugged here. Okay, great. So he was in the middle of these weird things called cluster headaches. It's very rare, evidently, but it's exceptionally painful. It makes a migraine look quite tame. At the time, I thought I was being a wuss coward. I was taking 12 strong painkillers a day and going, why do I still have a headache? And actually will have partial answer to his question why he was still having headaches, and how we would manage him here at the University of Washington. So now, coming from Dan and his headaches, the question is, why do people develop cluster headaches? And the easy answer could be it's complicated, or it could be we don't really know. Some of the evidence is in people who are now getting deep brain stimulators for treatment of cluster headaches. So there have been a couple of patients who had the electrodes in place in the hypothalamus, and one of the patients, while he was developing the cluster headache spontaneously, developed spontaneous discharges of hypothalamic neurons. So what you see on the screen is that prominent red peak in the middle of the screen, and this lasted only for few minutes. It was on the same side where he had the cluster headache, and correlated with the onset of the cluster headache. The question though is the hypothalamus the beginning of the cluster? Is there some other area of the brain that then pushes the hypothalamus into starting the spontaneous activation? We don't really know that. So what happens then? So when the hypothalamus, this is our theory, okay, of the cluster, starts being activated on the same side you have the headache. So, and there are a number of reasons, I'll talk about some of the speculations. So then what happens next, it will activate the alarm system of the brain. And you say, what is the alarm system of the brain? So we all have this trigeminal parasympathetic reflex, and all of the primary headaches actually share this activation of the trigeminal nerve and to some degree of the parasympathetic. However, the parasympathetic activation is much more pronounced in cluster headaches and other trigeminal autonomic cephalalgias. So what you have is you have the pingary hypothalamus activating your trigeminal parasympathetic reflex. Okay? So coming to that is, how do you diagnose someone with cluster headaches? So currently in the US and internationally, we use International Headache Society criteria, and in order to be diagnosed with cluster headache, you have to have signs of activation of the trigeminal nerve. And you say, well, how does it present? Extreme excruciating unilateral pain, usually periorbital. Now, the headaches usually last, and why I outlined it is because the duration of the headache, that's how you differentiate the different types of trigeminal autonomic cephalalgias. So in cluster, it's usually 15 to 180 minutes. And usually the attacks can be every other day to 8 attacks per day, and always in association with at least one autonomic symptom. So parasympathetic activation, so you can have lacrimation, tearing red, you can have on the same side of the headache. So not bilateral. Bilateral can be migraine. You can have nasal congestion, you can have sweating, you can have sympathetic dysfunction. So you can actually have Horner's syndrome during a cluster attack. If you, on the other hand, have a patient who has persistent Horner's, let's say for 12 hours, you should suspect that it's something else going on, such as dissection. And you don't want to diagnose anyone with their first attack of headache with a cluster. People need to have at least 5 headache attacks. And a lot of brain tumors and other brain lesions can unfortunately present with cluster headache attacks that will respond to treatment for cluster headaches. So just response to treatment doesn't mean that you have a primary headache. These are the headaches that you always want to do neuroimaging and differentiate secondary headache. Now, so again, unilateral, usually first branch, trigeminal activation, retroorbital distribution, 88% of patients, but they can also have activation of trigeminal nerve in upper teeth, jaw, less likely in ear. Now, this shows you that in all primary headaches, and the primary headaches are migraines, cluster headaches, tension type headaches, all of them have activation of the first branch of the trigeminal nerve. However, you can see the distribution in a cluster. This is here. It's really located around the eye. The migraine, you can see, is really much more spread, and a tension type headaches usually involves the whole head. So that's one clue. Now, autonomic symptoms, again, when you see them, and if you ask patients, they're very pronounced. It looks very abnormal, and it will be unilateral on the same side of the headache. So classically, the tearing, redness of the eye. You can again have ptosis, meiosis. Now, this is from a study. So Todd Rosen is one of the top headache specialists. He used to work at Cleveland Clinic, and last year he published the largest series of cluster headache patients in the U.S., and it was 816 males and 318 females, and he actually looked in the demographics, clinical characteristics, triggers, suicidality, and what Todd Rosen found that suicide headaches are associated with people who are suicidal. So 2% of people try to commit suicide, at least 50% or have self-injurious behavior, and 55 or more percent say that they've really thought about suicide. And what Todd points out, and I agree with him, is that we should really consider these headaches as neurology emergency because they're the most debilitating from all the headaches. They're treatable. The next point that he came up with is that there's significant diagnostic delay. So only about 20% of people are diagnosed at the time of the initial presentation. As you can see from this, some people take up to 10 years to diagnose. And so the question is, okay, I think from the first few slides that I gave you, you could diagnose a patient with cluster headache, right? You have 5 headaches, very severe excruciating pain behind your eye with autonomic symptoms. Should be pretty easy to diagnose. That's what you would think, right? So why is there the delay? And his speculation is that people can have migraine features or associated symptoms. I'll talk about that. There's also people who have migraines can develop cluster headaches. Females can have cluster headaches, and there can be also triggers for migraines that can be present in cluster headaches. So again, one of the reasons for delay, even though this is a rare headache type, it's only about 0.5% or maybe less than 1% of population. Still 500,000 or more people just in states alone. However, 1 woman per every 2 men. So if you have a woman in your clinic who's presenting with debilitating extreme headaches with autonomic symptoms, it could be a patient who has cluster headaches. Now, the other thing is when you look at the symptoms, and in our headache clinic, we have outline of all the symptoms. So for me, within a few seconds, I can see if people have associated autonomic symptoms, and I always ask about it as well. But if it's unilateral, not bilateral, unilateral, majority of the people will have lacrimation, so the orange kind of outline, lacrimation, rhinorrhea. But they can also have, in 40%, some associated, what we consider migraine features. And so a lot of physicians will just ask, okay, with your headache, do you have vomiting? Do you have nausea? Do you have light and sound sensitivity? And they say yes. You say, okay, your diagnosis is migraine, done, right? Next. And you don't ask about the autonomic symptoms. So I had just this week a patient who presented to me, a 45-year-old gentleman with severe migraines. And Kevin had actually had very debilitating headaches since he was 20 years old. He was diagnosed as having migraines. And so I started interviewing him, and I said, okay, so Kevin, tell me about your headaches. And he said, well, it's kind of weird. I have only headaches maybe 4 to 8 weeks out of a year. I don't know why. I don't really know what triggers them. And they're debilitating, and usually I have maybe 1 to 3 attacks a day. They usually last an hour if I don't treat them. And then I will not have any headaches at all for 6 months, and then the attack can come again. It's excruciating. It's always on the right side, and I have one-sided and autonomic symptoms. I said, do you have tearing, redness of the eye? Do you have congestion? He said, yeah, I have all of those. And sometimes my eyelid is droopy as well. I said, well, International Headache Society criteria actually calls your headaches cluster headaches, and I showed him, and he said, yeah, I meet all the criteria. That's bizarre, but I was called migraines for years. I just thought that, migraines are this severe. Well, so you could differentiate them with PET scans. However, we don't do PET scans, are only experimental, and they show slightly different activations of the brain that activate the trigeminal parasympathetic reflex. I'm not going to talk too much on this. This is just to exclude other cases. I'm so sorry, I'm moving here. So I'll talk the differentiation in a second. So I'm going to jump that you need to always proceed with good neuro exam and potentially neuroimaging. You really want to rule out secondary causes of headaches because they can present as the trigeminal autonomic cephalalgia. This is an example of the different studies that looked at what presents as chronic paroxysmal hemicrania, from stroke to macroprolactinoma, frontal lobe tumor, meningioma. Now, so another question that comes is, if you give someone a triptan and they respond to triptan, have you just made your diagnosis? Is your diagnosis then a migraine? Because I have many patients who kind of say, I know I have migraines because my primary, he gave me Amitrex and I responded to this. So actually, it does not predict response, and we say, why not? Because as I alluded to earlier, all primary headaches, whether it's migraines, cluster headaches, tension type headaches, activate the trigeminal parasympathetic arc. And what do you do with triptans? You just stop the activation of the alarm system. You're just binding to the serotonin receptors and stopping the pain, the alarm system of the brain. You're not treating the underlying cause that pushed the trigeminal nerve activation. So if you activate the trigeminal nerve with a stroke or a tumor, you can still stop the pain with a triptan. So if you have a patient in the ER and they respond to a triptan, you have not made your diagnosis of migraine. You need to go further and investigate. Now, so coming to the differential diagnosis of the different trigeminal autonomic cephalalgia, how do you remember which ones are which? So the shorter the name without the acronyms, the longer the duration of the attack. So the cluster has the longest attacks. Okay? So it's usually 15 to 180 minutes, on average an hour to 2 hours without treatment. Now, what about the other types of headaches? So paroxysmal hemicranias, so that's chronic and episodic. They're usually 30 minutes on average without treatment. What about SUNCT? And I'll tell you what SUNCT is in a second. It's just seconds. It's literally usually 5 to 10 seconds per attack. Now, the other thing that you can remember is, again, the shorter the name, the less frequent attacks. So cluster, probably maybe typically 1 attack a day, but it can be up to 8 attacks a day. However, if you go into paroxysmal hemicranias, up to 30, 40 attacks per day. If you start going into SUNCT, you can have 100 attacks a day or more. So more attacks. Now, as far as gender predominance, it's thought that cluster more common in males. Again, I alluded to that now we're considering that actually the 1 to 4 is more 1 to 2. That it's actually for every 2 men there is 1 woman who's suffering with cluster headaches. Chronic paroxysmal hemicrania is thought to be much more frequent in women and SUNCT in men. Now, so how do you treat cluster headaches? Depends, but the number 1 treatment, and for the boards, the treatment that you want to choose is oxygen. And I can tell you, I had a patient who's currently in Britain that I've just seen once in 2010, and he just sent me an email on Monday requesting my note to get oxygen treatment in Britain, because without a specialist, you're not going to be able to get an oxygen treatment. And he said, you know, you saw me only once in 2010. I started off and it was marvelous, stopped my cluster headache attacks. I haven't had none for 3 years, and now it restarted again. And I would like the oxygen again, but it's very difficult to get. So oxygen, if you say how effective is it, about 70% effective. How soon does it work? For most people, within 10 to 15 minutes. Some people say even within 5 minutes. Now I had a researcher who has many patents, and he assured me that the difference in oxygen and how well it works depends on how much blast you get. So if you use nasal cannula, not very effective. If you're blasted with oxygen, 100%, the highest, 15 liters per minute, you can really get very good relief very quickly. Now, what are the other options? If people cannot carry, and that's the one complaint that my patients have, that they do not get portable oxygen because insurances cover portable oxygen only for lung disease. So they have these big tanks, that are usually kind of at home, and they can use it at nighttime or when they're at home. But what do they do if they do have a diurnal attack? You want something fast, so sumatriptan, injectable, usually works within 10 to 15 minutes. Again, I had an email from a patient today who is actually a physician, and he ran out of the sumatriptan. I said, oxygen does not work for him. Sumatriptan works within 15 minutes, but yesterday he was out of his sumatriptan and the attack lasted up to 90 minutes. So it can be very debilitating. The other is DHE, dihydroergotamine. There are also studies showing Zolmic nasal spray can be used in other triptans, but you want fast delivery, so you want something injectable or nasal. Now, this always comes up, and I can tell you all of the patients that I have seen with chronic daily cluster headaches had medication overuse, and so we try to limit the triptans. This is tricky. And you say, how do you do it then? We always give them other preventive medications, not just acute treatment. But depends on the patient. So if they have history of chronic cluster, then I'm not going to give them more than 8 days a month, but I'm going to try to push other treatments. So what is the main number one effective treatment for cluster as far as prevention? Verapamil. And again, if you say, why does it work? Well, there are many speculative theories, but we don't really, going along that you decrease that excitability. You could speculate that you're, decreasing that spontaneous discharge in hypothalamus. And it works in majority of the patients if they can tolerate it. The biggest issue is, of course, hypotension and cardiac arrhythmias. What are the other options that you have? Lithium, Depakote, Topamax, indomethacin. Melatonin has been also researched, and Dr. Todd Rosen has published a melatonin cluster. It's actually on the family practice recommendations. I always recommend taking it for my patients, and they say it really, really helps. What about if you have tried everything, it doesn't work? What are the other options I have tried in the clinic? Occipital nerve blocks. So there is currently understanding that there is connection between the what they call cervical or occipital region along with the trigeminal. So any procedures that you do in the occipital area can stop trigeminal pain. And this can be just one time occipital block can sometimes stop that whole cluster. Sometimes I need to do 2 blocks. So you said, which ones do we usually do? We usually start with medications because that's more convenient for most patients, but if they're intractable, we usually do blocks. Now, currently, if you look up the latest literature I published in 2013, in the people who have extreme headaches, they have looked at sphenopalatine ganglion stimulators. That was published by Dr. May, and it's done in Europe. But those are $50,000 to $100,000 implants. So you have to always consider, what is the more easier way, and occipital nerve blocks are much cheaper. Stimulators, again, are really, really pricey, even though in their study it was super effective, showing that more than 70% of people responded. What they did is they implanted stimulator in all the patients, and then they activated it in some patients and didn't activate, and that's what they used, for their sham. Now, what about paroxysmal hemicrania? So, I mentioned that it's shorter, and you have many more attacks, and it can be both episodic and chronic. So we have a question here from Dr. Swanson. I'll repeat.
Going back to the 40s, maybe, there was a wonderful British neurologist, Sir Charles Simons, and he wrote a wonderful paper called A Particular Variety of Headache about cluster headaches. And he had patients who would have, every night, they would have a horrible headache lasting maybe an hour. And what he did, he would give them ergotamine, and they would inject themselves with ergotamine just before their headache was likely to come on, and that would keep them from having headaches. And then he wouldn't give it to them on Sunday to see if they were still in their cluster. So anyway.
So Dr. Swanson had a comment of a paper published in 1940s called Particular Types of Headaches by Dr. Who was it?
Sir Charles
Sir Charles Simons, who then was described what we call now cluster headaches with excruciating pain, autonomic symptoms, and he recommended using shots of ergotamine prior to the onset of headache. And basically what we do now, and it worked, and then he would usually stop it on Sundays to see if they still needed it. Actually, we do use dihydroergotamine, DHE. It's called DHE 45 because it has been available since 1945. And DHE is extremely effective treatment for any intractable headaches. The main thing is extreme nausea, vomiting, and people find the shots very painful. But this is one of the treatments we do use, and we train the people in the headache clinic to self-inject at home. So that's another option to triptan. So it's a very good point. Thank you. So why do I have indomethacin here? So if you look up literature, you'll find there's a whole series of what is called indomethacin responsive headache, and there's something magic about indomethacin. Melatonin has very similar structure to indomethacin, and that's why it's thought that actually in some of those indomethacin responsive headaches where you cannot tolerate indomethacin, you can tolerate melatonin. The problem with melatonin is that it's very difficult to absorb, but they have sublingual melatonin that is much easier and much more effective. So where would you use indomethacin? Anytime you suspect you're dealing with a patient with paroxysmal hemicrania, what it does, we don't have it available in States, but in UK they have injection indomethacin, and if you give injection indomethacin, you stop the activation of the brain, the hypothalamic activation that corresponds to the paroxysmal hemicrania within minutes of giving IV indomethacin. So the best would be to probably give people rectal or injection. We don't have that, we have oral. So how we do, we have indomethacin test where you take 25 milligrams 3 times a day for 3 days, then 50 milligrams 3 times a day for 3 days, discontinue after 3 days, and then see if there is recurrence or not. And you could say that's cruel, you know, right, to stop it if it's working and have the people have the headache again, but then how do you know if they need it or not, and if it was true test? Now, if you say, what if they respond? Then, per all the neurology review, you continue it indefinitely, which is difficult to do because of significant gastric complaints and renal, problems. So if you say, again, what do we do for people who are indomethacin responsive but can't tolerate it? You could use potentially other answers. You could use the melatonin, or you could look at other procedures to do to stop the nerve activation. So SUNCT, that's a very popular board one. So it stands for short-lasting unilateral neuralgiform headache with conjunctival injection and tearing. And so the main thing is redness of the eye, tearing. I've had only one patient in 10 years that I've seen that I diagnosed with SUNCT. Dr. Lucas, who works with me, has only had one patient. And what's interesting is, while I was talking to the gentleman, Moy actually saw him with me, he would develop redness of the eye and tearing with extreme pain, lasting just for a few seconds. Then it would go away. His face would normalize. It would look fine. And then a few minutes later, the attack would start again. And it was excruciating, just a few seconds, maybe 5 seconds. So what we did for him is we started him on Topamax and gabapentin combo. And we say, why did you do combination? Why didn't you just do one treatment? Because he was so excruciated with pain that we just decided to do double therapy and make sure that he didn't gain weight from the gabapentin. He actually responded to this treatment, and we just kept him on the treatment. And that's a good question. How long do you keep someone on the treatment? And do you then discontinue it after 2 or 3 months, or continue indefinitely? It's such a rare type of headache that I don't really have a good answer. So now, when you have a patient where they come to you and they're not responding to your treatment, or they're having daily pain, what usually goes wrong? So this is from Dr. Lipton, and when he analyzed all the factors that usually go wrong, his main, what he calls diagnostic and therapeutic pitfalls, what goes wrong. So I outline unrealistic expectations, and a lot of times we do not tell the patients that, okay, with, let's say, oxygen, 70% of people respond. It's not everybody responds. And a lot of the treatments, if they're preventive, they might not completely cure the pain, they might just decrease it. However, what I find in the headache clinic is rebound headaches and medication overuse. By far, all the patients that I've had with clonic cluster headaches, and I have one gentleman right now who presented to me 3 years ago where he had daily cluster for 2 years, where no one could help him, and he was overusing medications. He was taking daily triptans. So how did I manage him? Steroids, prophylactics. Now he's not had any headaches for 3 years. So it's very difficult. Where do you go, with this? And this is where actually I will end my talk. Thank you very much for the attention. Question. Okay. So there are no questions. Oh, good.
Can you have a cluster changing side? Say that 3 attacks a day, 2 on one side and 1 on other side, during same attack?
So Dr. Ashish Trivedi, who's actually also one of our headache specialists, is asking, can you change during the cluster episode of the 4 to 6 weeks or 8 weeks? Can it change side? So typically it's described that it should stay unilateral on the same side, but Dr. Todd Rosen described some patients who actually had bilateral activation of pain. It was really, really rare. It was like less than 1%. And there was one patient where it did switch sides. So, again, all the patients do not meet all our nice criteria, right? But whenever you have something, what I would again say on cluster headaches, whenever something is off, where it just doesn't fit the criteria, that's when you have to be more careful to make sure that you have the correct diagnosis and make sure that you're not dealing with something else. And the patients where I had also very intractable cases, they usually had some brain tumors or something else. I have one young gentleman, he's now in his 20s, and I have been treating him now for almost 7 years, but he actually has a lesion close to his hypothalamus. It's not operable, and he had daily cluster headaches, and we have him on daily verapamil. I've had him, and anytime he tried to wean off, the headaches come back. So again, have very high index of suspicion of something else, because on all the cases, all the legal cases, it was a secondary headache that responded partially to treatment. So the clusters, when they're activated with a brain lesion, that probably causes some discharges and activates that trigeminal parasympathetic reflex, you can stop that activation with medications. Doesn't mean that you cured the lesion. So I'm just being very aware of that. Go ahead. So question from Max Ma.
So the patient that you were describing with cluster headaches, you were saying that it was difficult to distinguish cluster versus migraine. Is that a case where it would be helpful to ask what you do when you get the headache?
So Max is bringing a very good point. So the question that he asked is, could you ask the patient what is the preference? And Dr. Spain, when I was doing the first rotation with him, he said, okay, Natalia, if you had 1 minute, what would you ask the patient, who had the headache, to try to figure out what kind of headache he had? And his correct answer is, what do you prefer to do when you have the headache? And if people tell you, I prefer to lay down, most likely it is a migraine. If they say, I prefer to pace around, but you have to also be careful how you ask that question, because I had one of the patients that I saw this week, I asked, what do you typically do when you have your severe headache? And he goes, oh, I'm pacing around. And then I said, what would you prefer to do? Oh, I said, I would prefer to lay down. Yes. So why are you pacing if you prefer to lay down, right? So go ahead. So
what
we
is
have
the pacing supposed to be?
So pacing, hypothalamic activation causes apparently aggression, and if you see some of the YouTube videos, I had YouTube videos here a few years back, but they didn't come through, so I decided not to bother with video this year. But you have people banging their heads, and the self-injuries where it's so debilitating that they prefer to just move around, they can't stay still, and it's considered that it's that hypothalamic activation. And if you put electrodes, the surgeons, in that area of the hypothalamus, you will actually cause that aggression and restlessness and that feeling. So go ahead. So Eric Krause has a question.
Yeah, a few years ago I read about a condition called SUNA, S-U-N-A. Does that fall into this category? What's the differences there?
So the question is, SUNA, and you're going to get me on the acronyms, but all of them are within that SUNC, SUNA, and right now it's in the attachment, even rarer than SUNC, because what is it missing? Someone will have to actually help me, but it was one of the trigeminal autonomic cephalalgias. And you said, Natalia, how do you treat SUNA? So it's one of the usually Lamictal, one of the anti-seizure medications, so not verapamil. But it's even rarer. I've never had a patient, that I could. So some people say that I just made up. It's when you go to the headache conferences, there's always a big discussion. Is it really a real diagnosis, or should we just call it SUNC, or differentiate it or not?
So,
So it's,
so in a SUNC,
Right.
there's a conjunctival
Right.
hearing
Right.
is there, and SUNA has
Right.
everything other autonomic, but not the conjunctival
Right.
hearing.
So,
That's the difference.
right. So what Dr. Shishtaredi said, remind me, so in SUNA, you don't have the conjunctival tearing, you have the other autonomic symptoms. But, if you were to say again, have you ever had a case in your practice? Did anyone here ever had a patient, that they suspected had So did you, Eric, have a patient that you suspect has SUNA?
No, but I've had one patient with SUNT.
Right. Yeah. So good. So Eric actually beats probably most people. You know, I've had also one patient with SUNT. And you know, the thinking again is that there is some spontaneous firing of a certain part of brain that pushes you into activating that trigeminal parasympathetic reflex. Now, the only other thing that I'm going to add, you can activate the same reflex in migraine. So in migraines, you can have autonomic symptoms. By that definition, they should not be as significant and bilateral, not unilateral. And, you know, so again, and some of the patients will not fit nicely, you know, the boxes and criteria, so then you diagnose them with probable and treat them the best, you know, you can. So, go ahead.
You mentioned verapamil. How about Diamox? The calcium channel ligand.
So the question is, you know, I mentioned verapamil for treatment of clusters. What about Diamox? I've never tried Diamox, and I have not. I can look at the research. I have not seen it used. You know, so the implication is, you know, could it work? So someone asked me years back, like, why don't we even use, you know, just phenytoin, you know, or you know, some of the older, and I think what it comes down to is people's comfort and what do you use and what are you used to using. So I mean, if you had an intractable person probably not responding to verapamil, you could try Diamox. I don't think it would be wrong. So Diamox does have significant side effects as well as verapamil. So I mean, that's the only problem is with verapamil is that I always start very low dose and just really gradually advance. But so far for all the patients that I have diagnosed with cluster, usually it works. If it doesn't work, then I usually go to occipital nerve block next. It's just really easy for me to do in the clinic. So I guess no other questions, so you guys have a break. Thanks. Oh,
One more question.
okay.
How often do you have to do the occipital nerve blocks?
So usually I can just do one time, or sometimes repeat one more. So it can completely, you know, stop that activation. It's really bizarre.
And you use just lidocaine or novocaine or
The lidocaine would be pivocaine, yeah.
and steroid?
Usually no steroid.
I hadn't heard
So-
of that before, and I thought that the literature on migraine suggested maybe it wasn't. They were trying to use it for migraine too, and didn't help so much. Or?
No, it can. So the question is, you know, can occipital nerve blocks be, you know, helpful in other headaches like migraine? And the answer is going to be it depends. You know, it's probably so. In a migraine, it would not be that practical to do occipital nerve blocks just because you have recurrences, you know, probably more frequently. You know, so we do more typically Botox, you know, and you inject the occipital area and the trapezius area with the Botox for migraine treatment. For cluster, if you have only that one episode that, you know, usually lasts, and the question is, why would it stop it? You know, and the current explanation is that sometimes or the people who believe in why would stimulators, you know, stop activation of, you know, something in the brain. So there must be some, you know, reflex that you have, you know, from periphery decreasing that central stimulation. So somehow the current theory is, but, you know, it's not proven. So how you would have to do it, you would have to put in, you know, the deep, whatever, that they had the electrodes in the hypothalamus, or do the PET scan and then inject, you know, or do the occipital nerve block and say, okay, are you stopping the intracranial activation? Are you actually from periphery? And that's the current theory, that with all these stimulators that don't work on periphery, that they actually stop the central activation of pain.
So you might have to do one injection per cluster.
Yeah,
Ah, I see.
yeah. So the, you know, the answer is one injection for cluster. Thank you very much.